So glad Sherry Gould is here to join us today. Before we join, we did talk about how it's so important to just kind of normalize the anxiety and depression that can come with Parkinson's, and just understand it can be a part of it, and that's okay. Anyway, today Sherry has joined us. She's a board certified nurse practitioner at Scripps Clinic Movement Disorder Center in La Jolla, California. She holds a Master's of Science in Nursing from the University of San Diego and a Bachelor of Science in Nursing from the University of Michigan. She is an expert DBS programmer, and she created a grassroots nonprofit organization which supports fundraising and education for research using patient-specific non-embryonic stem cell therapy for proposed long-term treatments for Parkinson's disease. Thank you so much for joining us today.
You are so welcome. I'm glad, definitely glad to be here, and glad to see so many people that have joined us today to talk about and learn about this most incredibly important non-motor part of Parkinson's disease. And my goal today is that all of you leave with a much better knowledge of not only depression and anxiety, but some of the other mood disorders as well. Let's see here. Oh. Okay, sorry. There we go. So these are some of our objectives. We're going to talk about the behavioral challenges that are most common in Parkinson's, and that includes anxiety and depression, apathy. Those are the three we're really going to focus in on. But I do want to touch on Parkinson's disease psychosis. Obviously, that's a whole lecture by itself, but it's so important that everyone out there is aware of PDP and how common it is. And then I really want to give everybody some solutions, some tools, not just for the patients, but for care partners and for families of when this part of Parkinson's enters into the picture. And many times I have to say is that this part of Parkinson's can enter into the picture before you even get diagnosed. So these chemicals in the brain can start changing way before you actually get a formal diagnosis of Parkinson's disease. So mood disorders are extremely common in Parkinson's disease. 70 to 80% of people with Parkinson's are going to, at some point in their Parkinson's journey, have experiences with anxiety and depression, apathy, and I talk about it as a triad. They're all connected and not in equal parts. So again, anxiety, depression, and apathy, all connected, not necessarily the same amount, not necessarily all at the same time, but they can occur in unison. So you can see here that we see 50%, one out of every two people, they're going to experience some kind of anxiety in the course of their lifetime. And we also know that these are much more worrisome than the motor symptoms of Parkinson's as time progresses. So we have a wonderful neuropsychologist who works at Scripps Clinic. Her name is Joanne Hamilton. And I take a quote straight from her: when mood disorders become so predominant that they begin to interfere with your ability to do day-to-day activities, these mood disorders need to be addressed. So please, let's keep that in mind as we move forward. So what causes mood issues in Parkinson's? There are three main brain chemicals or neurotransmitters that are involved not only in motor symptoms, but certainly in non-motor symptoms, specifically mood disorders and Parkinson's. And those three are dopamine, which we know is low. Serotonin levels seem to follow dopamine levels, so those also dip. And the third one is called norepinephrine. Norepinephrine and serotonin are both found in the brainstem, in the raphe nuclei and the locus coeruleus. These are two areas of the brainstem, not the brain itself, but the brainstem, that we know is affected by Parkinson's. We also know that anxiety and depression are caused by these abnormally low neurotransmitters, but can be exacerbated by a person's reaction to their diagnosis, to their changing roles in society, at their job places, a lesser ability to tolerate stressors many times that maybe they could handle before, and now they're much more difficult to actually get into perspective and handle them. So these are the things that we need to address in mood disorders. And we're going to start by focusing on anxiety. And when I talk about focusing on anxiety, I want to make clear that oftentimes these go in unison. So anxiety often can also go with levels of depression and vice versa. Apathy is right in there as well as part of that triad. So we think about anxiety disorders, and one thing we know for sure that if you look at the general population and the level of anxiety disorders people have as compared to Parkinson's disease, much higher rate of anxiety disorders if you have Parkinson's disease. And people describe it as this kind of feeling of heebie-jeebie, like it can be internal, the feeling of anxiety, or it can be external. So when we talk about internal, it is almost like feel like an internal tremor. It can feel like, you're just uncomfortable, kind of like crawling out of your skin, that you feel restless and you can feel agitated. A number of what ifs and questions that you cannot solve tend to come up over and over again, ruminating type of behavior. And when we think of anxiety disorders in Parkinson's, we think of three main types of categories, I should say, of anxiety. One is social phobia anxiety, and that can be just any given situation where you're out with a group, there can develop this anxiety from social discomfort, from being with lots of people. It could be because maybe your voice isn't as loud. Maybe you're not articulating like you used to. Maybe your tremor is obvious. Maybe your posture has changed, or your balance, or you're using a walker now and you weren't before. So that type of anxiety can come from that social phobia. We also have panic disorder type of anxiety, which we're going to talk about in greater detail. And that panic disorder many times will exhibit externally. And that can look like shortness of breath, even sweating, and just feeling really fidgety and uncomfortable. One of the biggest sources of anxiety disorders is on and off episodes. This is really interesting. So that tells us, as your provider, that we need to work especially hard to keep you in that therapeutic window, right? So I'm sure many of you on this call have heard the incredible lectures on PMD Alliance, and they've talked a lot about off episodes and on episodes and rescue medications, etc. But what we know is that many times when levodopa or dopamine levels are falling, anxiety can strike. And if we can keep dopaminergic stimulation nice and even in that therapeutic window, we can many times alleviate the anxiety that's caused from the peaks and the valleys of dopaminergic therapy. So we think about Parkinson's and anxiety, and then it just worry about things that you really have no control over, yet you continue to ruminate. Think about it over and over again. Just even things like being a burden, about your finances for the future, about cognitive decline that can happen, about falling, about your balance, financial future, you name it, you can tend to worry about it. And we know that occasional worry and anxiety that can happen when you can't get connected to your internet and you're about ready to give a huge presentation. That is anxiety, right? Your heart beats a little harder and you get a little sweaty underneath your armpits, but it goes away. The anxiety we want to worry about in people with Parkinson's is when it is persistent. It's not situational. It doesn't just go away. And those people really are just unable to relax. They feel very restless, not only inside their gut, but outside. Fidgety, moving around, can't get comfortable. You know, their muscles can get tight, not just their Parkinson's type, but they can have intermittent muscle tension. Again, sweating, shortness of breath, and we can see changes in both weight and changes in sleep. So typically in Parkinson's, we see weight going down, especially with anxiety and for a variety of other reasons. But again, we're looking for changes. And if it's different from their normal, then that's something that we need to pay attention to. Sleep can change with anxiety. People can have very little sleep because they wake up, they get anxious, they start worrying about things that they can't control, and then they're wide awake. And then, of course, lack of sleep leads to more Parkinson's symptoms. And then we think about that panic disorder as another type of anxiety, and that is cyclical. So someone starts being a little anxious, and when they're a little anxious, they get a little short of breath. And when they get a little short of breath, they feel that muscle tension. And when they're feeling that muscle tension and their shortness of breath, guess what happens? They get more anxious. And as you get more anxious, you get more shortness of breath. Your tremor gets worse. All your Parkinson's symptoms get worse. That feeling of internal angst can get much worse. So we talk about that as almost a panic attack. Panic is part of anxiety. Now let's kind of switch directions a little bit. Again, these are very intertwined, but let's talk about depression and Parkinson's disease. So depression and Parkinson's disease is just the sad mood that one cannot get rid of. It can last hour after hour, day after day, and week after week. It can persist for a very long time. There's a sense of complete loss of pleasure. The things that used to make you smile, grandkids walking in the door, or your buddies picking you up for a piece of pizza at the place, you know, down the street, a golf game, putting, whatever the case may be, that no longer brings you pleasure. And it's also like an inability to feel joy. Forget about the expressing joy, just to feel that excitement, to look forward to something, to feel happy. And we know that depression is definitely more than just feeling sad. It really can show itself with lots of different things, you know, unbelievable difficulty with making decisions. Daytime fatigue can be overwhelming. I will share a story with you right now. I literally saw a patient yesterday, and I've been seeing her for years. She has deep brain stimulation. I know her well, hadn't seen her. You know, typically we see our patients every 4 months or so. And she came in this time and something was different. She just said, I'm just so fatigued. I am just sleeping nonstop. I sleep from 7 p.m. to 7 a.m. and I take at least 2 naps a day that are 2 hours apiece. Say, you really take 4 hours of naps and you can still like sleep through the night? She's like, absolutely. So I'm thinking, okay, well, and she'd had a physical exam. It wasn't, that she was anemic or some other disease process was going on. So I looked at her and I asked her, I said, do you think you may be depressed? And she stopped and she thought about it for not very long, for maybe 5 seconds. And she said, I am absolutely depressed. And that's where we see that. And that is a red flag for us as a provider to ask these kind of questions when we see our patients have a change in their story, a change in their behavior, a change in the way they feel. Then it is up to us to ask the right question and get to the bottom of why that change has occurred. These patients also can feel guilty. They can feel worthless. And there is definitely a difference I'd like to speak of right now about depression and Parkinson's, and a depressive disorder as a depressive disorder can lead to a major depression. So a depressive disorder, it may be a little more intermittent. I had a patient tell me, I wake up every night at 2 a.m. cannot get back to sleep. I'm so depressed. And I finally get back to sleep. And then when I get up during the day and I move around, I do my rock steady, I'm so much better. But that time in the middle of the night, I feel very depressed. But those things we need to listen to, because that just depressive disorder, that a little bit more intermittent depression can lead to, if not corrected, a major depression. And when we talk about a major depression, that is much more difficult to get people out of a major depression and should be taken much more seriously by ourselves as your providers and by family members. We also know that depression and Parkinson's has been proven to affect cognition. We've seen in studies cognitive decline that are caused by anxiety, depression, and Parkinson's disease psychosis. And we also know that this issue of mood disorders can affect the quality of your life twice as much as your motor symptoms, twice as much. So this is something that we shouldn't ever take lightly. It's something that all of you should not take lightly and needs to be brought up with your family and certainly with a provider taking care of you. Now let's spend a couple seconds talking about apathy, because apathy is very different from depression. So the depressed patient may be laying in bed, say you're at independent living, you're at assisted living, and there's a bingo game, just for example. And it's the two of you always go. Your friend is laying in bed, they're depressed, but for many months, for many weeks, you always go to, Tuesday afternoon bingo, and you go to your friend's room and like, hey, Anne, let's go. Come on, it's time for bingo. And Anne, who is depressed, is like, no, I don't want to go. And you try every which way to coerce them into doing what is going to bring them joy, but they just can't go. The apathetic person will go, oh, really? Yeah. And you as a friend goes, yeah, this is what we do. We know we have fun. And you know what? You might win the 50 cents tonight. Okay. And that apathetic person will get out of bed, will put on their shoes, and they'll go down and play bingo and have a blast. They'll have a really good time. So they have not lost the joy of living. They have lost that signal that is telling that person you must get it done. They have lost a signal that says, hey, it's time to get up and take a shower. Hey, don't let that phone call coming in go to voicemail. Answer it. They've lost that oomph to tell them to act on what they know they should do. But if they have a friend, a care partner, someone at the place where they're living that can talk them into an activity, they do have the emotion and they do have the interest. once they are spurred into participating. So, and there have been some studies that have shown that one of our cholinesterase inhibitors called Exelon, and that may be helpful in treating apathy. Exelon, interestingly enough, of course, is a medication for memory disorders. But in some of the studies, they did find that Exelon, more so than Aricept or Namenda, seemed to be helpful with this issue of apathy. Other things we can do for that apathetic person is provide that structured environment, plan on some activities that are repeated at the same time during the week. So it can be anticipated, it can be planned, and va-voom, there's no chance to say no. If you take them, they will go. Important key to remember for all you care providers out there and spouses or friends of people with Parkinson's. Parkinson's disease psychosis. I'm just going to touch on PDP because I personally, professionally think that this is so incredibly important that everybody knows about. And though I think we are talking about it more at the clinic setting, we are not talking about it enough. And we are not educating our patients well enough to know that they have a 50% chance, or a chance out of every 2 people with Parkinson's, they have that 50% chance that they could be that one person who experiences Parkinson's disease psychosis in the course of their disease with Parkinson's. So PDP really does start with kind of a sense of presence, right? So you kind of feel like someone's in the room, they're looking over your shoulder, you look back and nobody's there, but it feels like they're there. From there, we kind of see a progression of what we call illusions. And illusions are there may be a belt on the ground that you forgot to put back on the belt rack, and just for a second, that belt looks like a snake. And you look again, and you can clearly see it's a belt. It is progressive, right? So like many things in Parkinson's, unfortunately, it is progressive. And so those illusions can turn usually into visual hallucinations. 90% of all hallucinations in Parkinson's are visual in nature, although it can affect any sense, any of your 5 senses. People can feel things that aren't there. They can smell things that aren't there, taste things, or hear things that aren't there. Anytime this happens, it's just really important that you talk to your provider and let them know that this is happening. And once you're educated that this is normal, that it can be treated, that we can look at your medication list and eliminate things that we know may make this PDP worse, and then certainly treat you with a medication called Nuplazid, which is really the only FDA-approved medication for the treatment of PDP. There are others that many people use, but probably not as effective as the Nuplazid or pimavanserin. Okay, so that was all the bad news. Now the good news. Now the good news. There is good news to all the kind of scary and kind of like, really, yeah, I think I feel that, I felt that, I can relate, I understand. I'm glad there's a name for it. I'm glad it's not just me and I'm depressed about my Parkinson's. Now that I know that it is a chemical imbalance that's causing it. So we need to let everyone on this call know that even though you do have a higher than normal propensity to experience mood disorders, depression, anxiety, apathy, PDP, we have amazing medications that we can use to treat it. We have incredible behavioral therapies that we can use to treat it. We know that a combination of medication and behavioral therapies does better than either one of them by themselves. But either way, there is a solution, and that's the most important thing. So let's look at categories of these medications we use in depression, and more so in depression, but also they tend to cover anxiety in many ways as well. The SSRIs actually increase serotonin in your brain by inhibiting the reuptake into the serotonin neuron. It keeps it in that synaptic space so the brain can use it. And these SSRIs are drugs that you may have heard of, like Lexapro, Prozac, Zoloft, Celexa, Paxil. These are very commonly used across the spectrum. Parkinson's are not, right? And then there's SNRIs, which are interesting medications because they don't only increase exposure of the brain to more serotonin, but they also increase norepinephrine levels. Remember, we talked about the 3 main neurotransmitters that go awry in Parkinson's. Dopamine, hopefully we have covered by keeping you in that therapeutic window. Serotonin, we can increase with a type of medication that increases serotonin and norepinephrine in that presynaptic space. Now, another bonus of both Effexor and Cymbalta also happens to be an SNRI, is that they treat depression and anxiety, but they also have the bonus of treating pain, which many people with Parkinson's have pain of some kind. And so it is kind of like a 2-for-1. We also have tricyclic antidepressants. We in our practice do not use those very often, nortriptyline, amitriptyline. These are very old-fashioned drugs that have been around since the 50s. They have a lot of properties of sedation. So the last thing we want for all of you is to feel sleepier during the day, but some people may still be using those. And then we have other antidepressants like Wellbutrin and Remeron. Remeron also is used more for sleep, just like Trazodone is an old antidepressant as well, but we use those to help people sleep and not so much for depression. Wellbutrin is an interesting antidepressant because it does not have sexual side effects. Not that all of these do, but some of the SSRIs may have the propensity to cause sexual side effects. Wellbutrin does not. So for some people, that is a good choice. But that being said, I have to tell the group that there have not been as many studies using Wellbutrin in Parkinson's as there has been with things like Lexapro and Effexor and Cymbalta. So just to talk a little bit more about Effexor, venlafaxine is actually the generic name. It's, again, it's super cheap and affordable. It's generic, yay. When we're dealing with such a big world of brand name drugs that certainly add up and definitely hurt the bank account. Believe me, I'm very aware of that. We know that Effexor really does, in a couple clinical trials that have been conducted more recently, that Effexor has the best evidence for effectiveness. And again, it addresses both the pain and the depression in Parkinson's. So now let's talk about non-pharmacological solutions and suggestions. So we know that talk therapy is excellent when combined with one of these medicines that helps regulate these abnormal neurotransmitters in your brain. That talk therapy is very effective. And one in particular, which is called cognitive behavioral therapy. This is a therapy technique. This can be given by clinical social workers, by psychologists, neuropsychologists, psychiatrists, not as much anymore, as most of you may or may not know. Psychiatrists tend to be more on the medication side of your mood disorders, more so than like cognitive behavioral therapy or CBT. We know it's super effective for depression and anxiety. And the way it works is that They use both a behavioral piece and a cognitive piece. So the behavioral piece is the patient, the client who engages in cognitive behavioral therapy must agree to do their part of it, to participate in the success of this therapy. And their part is they must exercise every day. They have to move their body. They must exercise. They must agree to do whatever they can to move their body daily, not 3 days a week. Number 2, they must agree to having social interaction at least a few times a week, whether that means a support group, rock steady boxing, tremble clefs, meeting with your neighbors for dinner, having family over, you name it. Social interaction is key. You want to be involved. You want to be part of society. Do not isolate. And thirdly, in the behavioral piece, the agreement is that you will do something that you love to do every day. And that thing you love to do could be, I love to snuggle up with a good book on my couch and read a chapter. I love needlepoint. I love to go out to the putting range and just putt a few golf balls. Whatever it is that every day you promise yourself, you are going to do something just for you that you love. The cognitive piece of CBT is the therapist really helping you interpret how you're looking at things in your life. What they try to do is, and they work very effectively in changing patterns of negative thoughts of poor self-worth, thoughts of guilt. So every time you start thinking this way, we're going to give you an exercise to turn that spiral that's going down and down, to turn it the other way, to stop those negative thoughts, stop those negative feelings, and change that cognitively. Between these two, cognitive behavioral therapy has been found to be very effective in treating mood disorders in Parkinson's. And then, of course, my favorite slide on the planet is there is nothing that exercise does not help in Parkinson's, right? It helps everything. If I quoted every single one of the hundreds of studies that have been done specifically in Parkinson's and the benefit of exercise, this entire lecture would be about those articles. But we know that exercise helps with mood disorders. It helps with cognition. It helps with your balance. It helps with your digestion. It helps with constipation. It helps with your sleep in every way. As a matter of fact, if I have a patient that comes in to see me and they're like, I am just not, you're right, I'm depressed, I'm anxious a lot. It's really prohibiting me from doing the things that I always have done. But I want to take another pill. I already take enough pills between my Parkinson's and my cardiac issue, and then I've got this thyroid thing. No, I'm not taking more medication. And no, I don't believe in therapists. I'm not going to go see a social worker or a shrink or a talking person to tell my problems to. And what I say to them is, okay, I respect that. Of course, I respect that. It's their life. I'm there just to give suggestions. But what you can maybe agree to do is promise that you will put in 30 minutes a day of exercise, of something that is pushing your limit a little bit, something where you're breathing a little bit harder, something that even may make you sweat a little bit. Doesn't matter where you are in your Parkinson's. If you're doing chair exercises, yoga, if you're out walking the beach or walking the mountains or taking a nice hike in your neighborhood, but that you're walking and you're exercising with purpose. So we know, the studies show us that people that do that kind of exercise have an improvement in mood with just doing that and that alone. Exercise is medicine. So what is the impact of mood on care partners? So there is an incredible amount of emotional strain on care partners of people with Parkinson's that are suffering from anxiety, depression, and apathy. They just don't understand, like, why. Okay, so my loved one may have apathy, but if I go ask him or her, let's go to that support group, and finally he or she agrees to go and they really enjoy it once they're there, why can't they just do it on their own? They can't do it on their own because they have lost that signal that I should do it, right? But it's very frustrating for care partners. It's very difficult and overwhelming. And care partners, we have seen in more studies that care partners of people with Parkinson's suffer from more depression and anxiety themselves. Social isolation because they feel like they need to be with their loved one nonstop. The loved one trusts them, wants them with them all the time. This leads to incredible amount of fatigue, even anger, a sense of just being overwhelmed and saddened. All these feelings lead to the same things we're talking about: weight loss, weight gain, problems with sleep, all sorts of problems, and can lead to lots of arguments with their person with Parkinson's. All of this amounts to care partner stress, right? Lots of care partner stress. It is a huge responsibility that all of you out there that are care partners are taking on. And I acknowledge that, and we all acknowledge that. And I'm sure your person with Parkinson's acknowledges that. And so there is definitely things that can be done to help that situation. I mean, you can read this as well as I can. I mean, these are all things that you might be feeling if you were with your person with Parkinson's that requires a lot of your attention, that you may be feeling all of these type of things. And feeling like there's nothing you can do about it. Your primary responsibility is to your spouse with Parkinson's. But I encourage you to take a personal inventory and think about these questions. Are you able to get uninterrupted sleep most nights? Do you have even a little bit of alone time during the day where you can just go in the other room, go out for a walk around the block, hopefully meet a girlfriend or a guy friend for a cup of coffee and conversation? Do you have like a person that can relate to what you're going through, that you can sit down and share ideas with? Things like that come up all the time in support groups. The fact that you're on this call, you're on this Zoom learning about mood disorders and Parkinson's tells me that each and every one of you wants to learn, wants to have better command of their Parkinson's disease. Also know that you want to reach out and you want to socialize with each other. Thank God we have Zoom. We'd never be able to reach as many people. But the other post-pandemic, is incredibly, incredibly important. So navigating through the emotional challenges of Parkinson's, educate, get support, and find resources. So when you are dealing with mood changes in your person with Parkinson's, I want you to try to limit the distraction for that person and limit the choices. So if you're making dinner for your loved one with Parkinson's, don't say, hey, are you in the mood for a hamburger, or do you want to go out, or should we have the kids over and make macaroni and cheese? Just say, guess we're going out tonight. The kids are coming over. The grandkids are coming over. Just kind of help limit the choices. Things that will limit stress for you and for your person with Parkinson's that may be experiencing stress of anxiety and depression is kind of limit distractions. To have 8 or 9 people over at one time won't be good for anybody, right? So that person with Parkinson's, not always, but the person who already is showing you that they get anxious when there's a lot of people around, just don't stop it, but just maybe limit and simplify the daily schedule, just to maybe 1 or 2 events a day. But one of those events should be daily exercise. Another one, at least, definitely, hopefully every day, but at least a few times a week, should be that social activity. And then, of course, your care partner daily schedule, at least a few times a week, should be time that you're able to get away, that you're able to meet someone for a walk, or meet someone for coffee, or just get on the phone in a different room and get some support. So it is incredibly important that you take care of yourself first, or you'll have nothing left to give others. And self-care is not selfishness. You cannot drive your truck without wheels. It is not selfishness. You cannot serve others from an empty vessel. So please, please take care of your health, take care of yourself, recognize that you need time on your own in order to be the very best person you can be for your person with Parkinson's. And accept help from friends and family. The ones that do best are just like so-and-so may call and, hey, can I just drop off? I don't know, I had some extra barbecue chicken. Can I drop it off and just say a quick hi? Is there anything I can help with? Can I maybe run to the grocery store? Don't say no. People want to help. They want to participate, and sometimes they don't know how to. So don't be afraid to ask. Don't be afraid to ask your neighbor, I just have to get away and I have to get my hair done. Would you mind coming next door just for like an hour and a half and sitting with my loved one with Parkinson's? If you're at that place, speak up and don't isolate. Make sure you're getting that sleep and go to your support groups. And for goodness sakes, please be open with your family and friends. They do not know what you're going through unless you tell them what you're going through. And more ways to manage your stress. Again, this is for the care partner, which is equally as important as a person with Parkinson's. Again, call that friend, schedule a massage, watch that favorite TV show. Again, I've said it a million times, you hear it with every presentation given on PMD Alliance and every support group. Exercise, 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 tend to the garden, and remember things like deep breathing and yoga and things that will help you manage the stress of being a caregiver. And here's some resources. Psychologytoday.com is a really good one. You can go on that website, and it literally has psychologists and social workers that are available to you either in person or online. You can enter your insurance, you can enter your zip code, you can enter what type of therapist that you want to talk to, say about cognitive behavioral therapy, and it will pop up with people that are in your area, whether they're online or you can go see them in person. Now, this day and age, we can start doing that again. But there are resources out there. Of course, the Parkinson's Association .org, that's our local organization. I'm sure all of you that are listening have, or hopefully you have local organizations. And if you don't, link into any of these from another city, it doesn't matter. The one beauty of the pandemic is that we definitely learned how to work remote and be educated remotely. Okay. All right. So not sure why that just ended, but yes. So I just wanted to finish and tell everyone that that Parkinson's disease does have a huge element of anxiety and depression and apathy. But the most important message that I want people to carry away from this is that it can be treated. So don't hesitate to reach out to your provider and know that it is a chemical imbalance that can certainly be treated by medication as well as by therapy. So at this point, I would like to open this up to any questions that people may have. And I will try to answer them to the best of my ability. Hi, everybody. Okay, can I hear? I think, yeah.
Yeah, just want to make sure if you could hear me.
Okay, I can hear you, yeah.
Can you? Okay, perfect. So somebody came with a question that they've read an overactive basal ganglia is associated with anxiety, increased awareness, heightened fear. Underactive can also cause problems with motivation, energy, and apathy. But then what they found is that highly motivated people have had their brain scans, and it shows that they also have that overactive. So they too are prone to anxiety, but they seem to focus on it in certain ways. So the question is whether increased activity like exercise would be shifting the concern from self to others, maybe volunteering or whatnot, regaining a higher sense of purpose would be helpful for those who suffer from PD anxiety.
Absolutely. I mean, exercise definitely increases endorphins. And when we increase endorphins and increases dopamine, right, it stimulates dopamine even production from the cells that are still making dopamine. These type of things are incredibly important in managing mood disorders in Parkinson's on all those levels that I had talked about before. I love that you brought up sense of purpose, because those are other suggestions, like get out of your own mind, right? We can get obsessed with your Parkinson's and your symptoms. It can become overwhelming. And especially if you start ruminating, it's about me, it's about me, it's about me. Oh my God, what's happening now? And now I have to take it's a constant reminder, right? Set my clock. I have to take my medicine every 2 hours, every 3 hours, every 4 hours, whatever the case may be. I cannot encourage this group enough to find some sense of purpose. And one of the best things that my patients have found is like volunteering at an animal shelter. How great can that be? I mean, they don't care if your voice is loud or if it's soft or whatever, and they love all of us equally. Or giving back for a Boys and Girls Club, or volunteering at a local library and maybe reading to some kids. But I find that my patients that are the most successful are the ones that live beyond their Parkinson's. Yes, it's there and it's sitting and staring you in the face all the time. But to get distracted, to give to others, is one of the best sources of medicine, certainly for mood disorders and Parkinson's.
And then we have a couple of questions about medications. Someone wants to know if it's safe to take SSRIs every day.
Yeah, so SSRIs, I probably failed to mention, you have to be patient. SSRIs and SSNIs take 5 to 6 weeks to take effect. So if you have a lot of anxiety and your provider decides to put you on one of these medications we talk about, you may need, until that kicks in to help with your anxiety and your depression, you may need something like a benzodiazepine, usually a long-acting one that's not as addictive as things like Xanax and some of the shorter acting that kind of solve the problem temporarily for a period of time, and then the anxiety comes back and you have to take more and more. But SSRIs need to be taken every day. You don't take them as needed ever. They once you take them, you'll be taking them forever, because again, I want to remind the group, this is a chemical problem. It's biologic in nature. Just like you have to take levodopa to help your dopamine levels go up, you need to take things like SSRIs, SSNIs in order to increase that norepinephrine and the serotonin in your brain.
And then someone also asked, if you talked about clonazepam, is it appropriate to take that as a sleep aid?
So we use clonazepam very often. It is a drug of choice for another condition called REM sleep behavior disorder, right? Really important is when you talk and act out your dreams. So there's a little nucleus in our brains that when we go to sleep creates a natural paralysis in our bodies that allows us to dream quietly, but not talk and act out our dreams as we're dreaming, because we know we all dream. So we use clonazepam to put people in a deeper sleep for REM sleep behavior disorder. But at times, in tiny doses, we can use it to help treat anxiety only until our SSRIs kick in.
And then somebody had also asked if everything you're recommending can also be used for when someone has Lewy body dementia.
So yeah, absolutely. Any kind of anxiety disorder, when I talk about the medications we're using, these medicines are used across the board. Everything I've talked about in the world, all of our world of mood disorders, we use the same medications. We use the same medications to help us get through these tough times with anxiety and depression. So I am not recommending for whoever asked that question, you personally. Obviously, you need to bring it up with your personal provider and see how they will choose to treat you for that. But yes, as a general rule, anxiety, depression are treated with these type of medications we've been talking about.
And then one thing that's come up in one of my support groups is they kind of talk about, it's not so much apathy as much as they call it the inertia sometimes. And you kind of touched upon like losing that drive. And so, for example, someone might be really interested in like doing crossword puzzles. So it's like, well, I'm happily doing my crossword puzzles, but that's not getting my groceries, you know. And so we kind of debated, like, is that apathy, or is that just kind of almost like, well, I'm content right now, so I'm not really feeling, or is it just because the drive is sort of gone? How would you describe that?
Of things. I think that, you know, the drive, that message telling your brain logically, it's time to go grocery shopping. We're out of milk. When am I going to put on my cereal? So that message in our brain that logically prioritizes playing crossword puzzles versus grocery shopping for milk that you know you're going to need in the morning, and it's just hard to get motivated, can be part of apathy. Or Parkinson's is complicated, right? It can be a bit of compulsivity, right? I'm playing this crossword puzzle, I just can't stop. I just can't stop. I got to play it. I got to play it. No, and it's just, that's another whole part of behavioral dysfunction or challenges, I should say, not dysfunction in Parkinson's. That seems to be more dominant in Parkinson's. And one needs to recognize that. And so if it's a repeated pattern, and every time someone sits down to play a crossword puzzle and they just are playing for hours and they just can't break their attention, that needs to be brought up with your provider, because that's more of a compulsive behavior.
Mm-hmm. Then we also had a question about, as a caregiver, how can you encourage exercise? It seemed like you kind of talked about maybe let's do this together. Are there anything else you think about? You know, that you would
right, and that is a difficult question, because as I talked about before, if people are in a depression, if they're in a major depression, unless those chemicals are changed in their brain, they're not going to even see the value. They will find no joy or no reason to get out there and exercise. So one needs to really be astute and bring it to the attention of your provider so they can help evaluate, is this just a little bit of apathy, or is this patient depressed, or is it that they really have a fear of falling? That's why they don't want to get out and walk. But most of my patients and their care partners do much better when they do it together, or they have someone directing, right? So I think the majority of people with Parkinson's, it's hard to get motivated and go, oh my gosh, it's 52 and cloudy and kind of foggy outside. I know I don't want to walk, versus the friend that comes by or the spouse says like, nope, we're just going to put on our, our little slicker things. And, if we need to take a little umbrella in case it starts raining, but we're going to go out because we're going to feel so much better when we do. Or there's so many choices online and in person. Everything from, of course, Box Fit, Rock Steady Boxing, Parkinson's exercise classes. And it doesn't have to be Parkinson's, for goodness sakes. It can be Pilates, it can be yoga. But when people see that you're there, they look forward to seeing you. That many times gets people over the hump. I really don't feel like going to Rock City Boxing today, but Mike, Mike Reeder, he's going to know that I missed. And so that definitely brings, again, a motivator. I think it is always more successful exercising with others than exercising by yourself.
We are almost out of time, so I did just want to thank you for doing this. Some people have asked if they could become your patient. Thank you. We do have a tradition here at PMD Alliance. Oh, also we did put, before I forget, some links in the chat. So I do encourage you to save your chat. If you click on the 3 dots on the bottom of your chat, you can save it that way, because Sherry did provide some links. The PowerPoint as well as the video will be available tomorrow. And again, we thank you. Our tradition here at PMD Alliance is our wave of gratitude. Thank you so much for doing this today. This was lovely.
You are so very welcome. Thank you, everybody, for learning and listening, and make sure that you and your provider are talking about those non-motor symptoms of Parkinson's. Remember, those are the ones that affect the heart, the soul the most. So make sure you're talking about it. It's important. So thanks for listening, and have a great rest of your day, everybody.